Space. So you should be set up. If you would like, you can just manually unmute.
Sorry. How do you manage a hemorrhage and trauma? Because when something's traveling 17,500 miles an hour, if it collides with something else, that's an awful lot of energy. And right, that's probably going to be a level 1 trauma activation as a result. So Megan MacArthur said this quote, and it's going to apply to what we're going to talk about for the rest of the talk. Things that are very, very simple on Earth suddenly become really hard. Even something simple like sleeping or brushing your teeth, you have to really think about it. How am I going to do this successfully, and how am I going to do it without making a mess? And right, if you run a code here on Earth and you open up a package and drop the wrapper, it goes to the floor, right? And then you kick it under the bed, and housekeeping comes in and cleans it up when you're done. You do that in space, it'll end up in your face, it'll go down the hallway. You have no idea where it's going to go. Same thing if you get a bleed of some sort. Normally it ends up on the floor, so you hope that you've got shoes that are waterproof. In space, that's not true, right? You want to have glasses on because that fluid's going to float, and I'll show you what it looks like. So you can make a mess pretty easily in space. And then Doug Hurley, who was a Demo 2 astronaut, said people to a degree think it's pretty glamorous to be able to go into space, but it's actually like a really messy camping trip. So a mess is a big deal to these astronauts. So somehow I managed to get through a couple of lectures yesterday about aerospace medicine and didn't have this slide. That's rare. You pretty much see this slide in every single aerospace medicine talk that anybody will give. This is what aerospace medicine is. We're going to take, historically, we've taken very normal physiology and we put it in a very abnormal environment. And when you get into space, it's an extremely abnormal environment. That's changing with the advent of commercial space, right? We're now going to start taking abnormal physiology. We're going to take astronauts who don't necessarily meet NASA's criteria to be an astronaut, that have some sort of chronic medical condition, some baggage that they're bringing to the table, and we're going to put them in that abnormal environment. So things are going to change, right? What used to be a very healthy protoplasm in a very unhealthy environment is now potentially going to become the worst of worst, right? The abnormal and the abnormal. So this is one of the things, Smith Johnson is one of my colleagues at Axiom. Tom Marshburn is currently on the space station. He's an emergency medicine doctor. He just launched on Crew 3. This is what I aspire to do with a journal article, right? Here's your 2-sentence abstract, and now you can publish it, please. But I think it sums up exactly what emergencies in space are. It's inherently risky, manned spaceflight, and the results are, where you get some unique problems from a trauma and a medical perspective, and managing those, right? You're going to take the special physiologic and environmental conditions of space, and you've got to be able to manage badness when it happens. And how are you going to do that? Because as you'll see, the physiology, once you get it into that abnormal environment, things start to change. And things as simple as drawing up code meds suddenly become very, very complicated. We are fairly early on in spaceflight, right? From a historical perspective, we've had about 60 years of manned spaceflight. We've had 600 astronauts go to space, so we don't have a whole lot of data. It's only in the last little while that we've really started pushing the envelope from months to years in space. And if you want to colonize a planet, there are people that are going to spend lifetimes in space. And so what happens to our physiology there? And you can see that the Soyuz has been present pretty much all the way through. So the Russians are still flying basically the exact same capsule. They've flown all the way along. We've gone back and forth with different capsules to the space shuttle, and now back to a number of capsules here. And you start seeing some of the commercial providers coming in. Despite having that low amount of data, right? 600 people, 60 years of flights, we have had some disasters, and they're important to remember because there are a lot of lessons that we've learned from there. So the Challenger is the first one on the left, and we learned that pressure suits were required for our astronauts, something that the Russians had learned about 15 years earlier when they had 3 cosmonauts come back dead as a result of the decompression of the capsule. But because of where things were with the Soviet Union and the United States, some of this information didn't get shared back and forth. And so we thought that the space shuttle was going to be the safest vehicle ever, and didn't need to have an escape system or a real robust life support system in the form of a pressure suit. That changed. And then after Challenger, everybody started wearing pressure suits when they flew the shuttle. We had Columbia break up, and we have had a commercial space accident with Virgin Galactic Spaceship 2 in 2014, and that killed one of the pilots, and the other pilot survived, but he'll never fly again. So this is the Soyuz 11 in 1971. This is the one that had a decompression leak. It was a very slow leak inside the capsule, slow enough that the cosmonauts did not detect that it was occurring. They didn't put their visors down because they didn't think they had to at that particular stage in flight. And as a result, they came back. Two of them had agonal vital signs. And there's video of the medical crew here that you see opening the hatch, trying to resuscitate these folks. And so it's the only time we've actually tried to resuscitate somebody who's gone to space and come back ill or dead in this case. The Challenger and the Columbia, those weren't survivable events, and there was no medical intervention that was performed on those astronauts because it was so severe. So we do have capsules that leak. We are going to see some health issues going to space, and if you saw the presentation yesterday, we talked about this. These medical results are all published. The astronauts were very good about letting the scientific community publish what we learned from these folks. So this is Richard Garriott. He went to space in the Soyuz. During his workup, he got a CT and had an incidental finding of a 13-centimeter liver hemangioma. That then NASA said there is no way, no how that you are flying that to space. So it needs to come out or he doesn't go. So he had an elective resection of the liver hemangioma to qualify to fly to space. And then this is Gregory Olson, 57-year-old, also flew to space, had a 35+ pack year smoking history, and you can see his medical problems documented there. So he flew to space. We learned a lot from him. He also had a Soyuz depressurization on reentry, not as severe as the Soyuz 11 one. But for somebody who's had pneumothoraxes and has COPD and blebs, right, you have a depressurization of any sort, you're potentially going to have another pneumothorax and some problems. Luckily, he did just fine, but it's concerning. And then you can see ventricular atriolectomy. So he had some arrhythmias during the workup, a couple of masses that were probably something not cancer, presumably. But right, you don't know, 35+ year smoking history. Those are some concerns. So space is inherently dangerous. It's a hostile environment, and that's why people wear the suits and right get the radiation protection and the pressure suits for everything that they do. And those suits, so the EVA suits, that now EVA is a spacewalk, extravehicular activity. The suits that astronauts wear when they go outside of the space station to a spacewalk cost on the order of millions of dollars. The pressure suits themselves that they wear inside the capsule during launch are over $1 million a piece as well. So it's a hypercarbic environment, which surprises people. The CO2 on the International Space Station is 10 times what it is in our atmosphere. And that's significantly better than what it was 20 years ago. We've gotten better and better with scrubbing, but it's an entirely enclosed environment. So if you're exercising, just living, the CO2 levels can go up. And if you watched Apollo 13, that was the big concern, right? That was the round peg that they were trying to put in a square hole, was the lithium hydroxide scrubbers that you use to scrub CO2 out of the environment. And so if you have a problem with that, then what you end up doing is you end up telling the astronauts, basically, you're going to take a nap for a while. And you try to get them into as close to a steady metabolic state at as low a level as possible for as long as you can until you can fix the problem. We have fluid shifts. There's an increased rate of renal stones. I think it's due to the skeletal unloading and the loss of bone mass. There's some heart remodeling, particularly on the right side of the heart, because of the increased fluid volume that comes back to it. And I'm going to show you some slides about that. Radiation exposure is a big and controversial topic. Jeff Chancellor is probably the expert on it if you're interested in that. He's got a number of papers that he published. And his wife is Serena Anand-Chancellor, who flew to space on Expedition 57. And she's a internal medicine and aerospace doc. Decompression risks, we've talked about. Thermal extremes, right? It goes from very hot to very cold because there's no atmosphere. And so if you're in the sunlight, then you're being heated to the order of a couple hundred degrees. And if you're not in the sunlight, then it becomes exceptionally cold, below freezing. And every 90 minutes, we're doing an orbit on the space station. So you've got 45 minutes of direct sunlight and then 45 minutes of complete darkness, 16 times a day. Thrombotic events, we just had a case of that. And actually, that's Serena Anand-Chancellor had that event. She had a DVT in the IJ, published in JAMA in December of 2019. And it caused all sorts of concern. Because what do you do if somebody has now got an acute thrombus in the IJ? And it happened to be that we had some DOACs on the International Space Station there for research purposes. So she was started on those. But then you have the concern of how do you bring this individual back, right? You put them on a blood thinner, and now you're going to bring them back in to land on land. And there's a pretty good thump. And there can be an even bigger thump if the parachute doesn't open or if the landing's off nominal. And if you've got somebody that has a car accident on Lovenox, right, it's a bad day. So if you have somebody that has a spacecraft accident on a blood thinner in the middle of Kazakhstan, that's potentially a very bad day. You lose bone and muscle mass. There's a very big infectious risk. There always has been. It's come more to the forefront now with COVID. Crew 3 was delayed in launching. It was supposed to launch on Halloween. It ended up launching on Memorial Day or Veterans Day, sorry. And that delay was due to an infectious concern or an exposure and a sick astronaut inside of quarantine. And so you don't want to send somebody up with something contagious, because you send them up to the space station and they're sick. Now everybody's sick. Pretty much 100% that anything infectious, everybody's going to catch. Ecless environment, environmental control and life support system. So you are entirely dependent on a system to maintain your living environment to a level that you can live in shirt sleeves. The trauma risk, toxic exposures, we're going to talk about hypergals in a little bit. Mental health becomes a big thing, and I talked about that yesterday, right? You spend 6 months inside a small tin can with 5 other people. You all better play nice in the sandbox. And if you don't play nice in the sandbox, it's going to impact the work environment and the living environment, and bad things are potentially going to happen, especially, right, if we now go to another planet, and that's right, that's where you are. If it's a one-way trip, then that suddenly becomes a real big concern. And if we are going to do a one-way trip, and NASA doesn't like to talk about this, but they're going to have to at some point. But I don't think their PR people are ready to talk about sex in space, but reproductive health is going to become a big thing, right? There's some discussion that sperm get very, very confused without gravity and have no idea which way to swim. So if you have no idea which way to swim, future generations may not occur, or they could be dizzy. So the challenges are that there are a very limited number of events to draw information from. And the limited events that we have primarily are happening in very healthy young people. And up until very recently, it was predominantly healthy, military-aged white males, right? But now we're starting to get a more diverse group in the astronaut classes. And we're going to have Artemis is being billed as the first woman and the next man to walk on the moon. So history is going to change, and we're going to start learning some more from that. There are mass and weight limits in terms of what we can launch, shelf life and expiration dates, right? It doesn't matter here in a hospital because we're just chewing through supplies really quickly. But if you send a bunch of stuff up to the space station that's heavy and right, that's expensive to launch, and then you don't use it because very few events happen, and now they're expired, now you've got to resupply them. And so it was expensive to have it up there. It's then expensive to replace them. Somebody's got to maintain that inventory. Somebody's got to check those expiration dates. Somebody has to maintain the storage for some of this stuff, right? Some things need to be temperature controlled. It becomes very, very difficult. And because some of this stuff may be performed by people that aren't medical, because you're not guaranteed to have a doctor on board right now. That's going to change. Varied levels of medical expertise and autonomy on board. If we go to Mars, it's going to be a 20-minute comms delay one way. So try running a code with somebody that doesn't know how to run a code over the phone, where you tell them to do something. 20 minutes later, they get the message. They don't understand it. So they reply with, say that again, pardon? So now you try to clarify it, right? That's just not going to work. So we're going to have to come up with a way to manage that. And then limit it to the level of care and evac options. Space medicine is wilderness medicine by the definition of wilderness medicine, that you're more than 90 minutes away from definitive care. If something bad happens on the space station, I can't get you to a hospital inside 90 minutes. So the astronaut population, these are the demographics all the way through NASA's selection. They're getting older, right? It used to be, it was young military test pilots were the Gemini and the Mercury astronauts. And then Apollo, we started bringing in some doctors and some older folks that were outside of the military. And now we've got men, women, all sorts of different professions, from geologists, meteorologists, engineers, physicians. We've sent a couple of politicians in the past. Unfortunately, we brought them back, but can't change that. But it's getting older, right? You can see that the average age at selection used to be in the early 30s. We're now getting into the late 30s. The oldest astronaut that's ever been selected is Don Pett, was selected at age 46 after something like 13 or 14 application rounds. And Don is by far, I think, one of the most interesting astronauts. If you ever get a chance, Google some of his TED Talks. He's Bill Nye meets Sheldon Cooper. And he's an incredible personality. But we're getting older, right? You get American people that are going to space at 40 years of age. Some of them are probably going to be on something, right? A statin or an ACE inhibitor or a beta blocker, some sort of chronic medical condition, especially when you get outside of the traditional astronaut pool. This is the average age of astronauts on board the ISS, because just because you get selected at 38 doesn't mean you fly at 39. There's a 5 to 10 year training period before your first flight. So you may be getting close to 50 by the time you do your first flight to space. So even more risk of having some sort of chronic condition. We have had medical events, and these are some of the ones that I wanted to highlight. So we have had a case of urosepsis on Apollo 13, and the movie does depict this. The individual came back and basically collapsed after getting out of the helicopter and needed fluid resuscitation and antibiotics. We have had hypergolic exposures inside the capsule. And if you don't know what hypergals are, I'm going to tell you in a second. And there are very few things that scare me. Pulmonary hypertension is one of them, and hypergals is the other. And it's nasty stuff. And there's no way to do space flight right now with our current technology without hypergals. So we have to accept that risk. But it put 3 astronauts in the ICU for 2 weeks back in 1975. We had a liver toxin exposure due to an epoxy in the water system, a new water system that hadn't fully cured. And a number of the astronauts drank the water and said that it tasted funny. And when they talked to ground control, they started doing some testing and discovered that that's why it tasted funny. Then they started doing dose calculations for everybody that had, how much water have you had in the last 48 hours. And if you don't know anything about STS-95, that was John Glenn's return to space. So it was a big publicity event and had potential for coming back much, much earlier because they were worried that some people, the pilot included, had been exposed to a liver toxin that was going to cause liver failure. There was a fire on board Mir in 1997. There was the IJDBT, and then there have been multiple cardiac events and arrhythmias. Pretty much every spacewalk, somebody may have some sort of arrhythmia, PVC, or a small run of non-sustained BTAC, stuff like that. So hypergals are the fuel that we use in a vacuum. So on Earth, right, we use oxygen in a combustion engine. In space, there is no oxygen, right? You're operating in a vacuum. So we use hypergals, which is a fuel and an oxidizer, and the two that we use are monomethylhydrazine and nitrogen tetroxide. So one, if you see an orange cloud around a spacecraft, run. If you see some sort of clear liquid dripping, don't get it on your skin, don't taste it, don't assume it's water, because it'll be one of these two things. And these are the safe limits for this stuff. OSHA officially does not have a safe limit for exposure to this stuff, but there are tolerable limits after which it starts to become an irritant, both to the lungs, the mucosa, and your risk of getting cancer in your lifetime at a very low level. Very low level exposure is very, very high. It's almost certain, right? Every animal model, that's how they've ended. You expose mice to any of this stuff and they will get cancer eventually. For obvious reasons, we haven't done those studies in people. So it's a lot of it is case reports, but the people that do get significant exposures do develop cancer as a result of it. And so when the capsule lands, we do get leaks and we check for this. The space shuttle had leaks as well, but the space shuttle was big and it was out in a windy environment on the runway. So it was less of a concern. But you can see that, right, we're in the 5 parts per million is the sort of acceptable limit. We would prefer that it's less than that for one of these things. So it's a very, very small exposure. This is a chest x-ray from the astronauts on the Apollo Soyuz test project in 1975 that got us exposure inside the capsule. And you can see this is the pre-flight x-ray, fantastic x-ray technology they had in 1975 and then scanning it. But on the right, does anybody want to do a chest x-ray conference now? Is that still a thing? And then the one on the left is pre-flight. The one on the right is on admission to the ICU. Oh, yeah. So trust me, the pulmonary infiltrates, pulmonary edema there. Their blood gases weren't awful on room air. Their PaO2s were in the 70s. They all had a respiratory alkalosis. pHs were 745 to 751-ish on admission to the ICU. And they probably spent most of the time in the ICU simply for monitoring. Nobody got intubated. Nobody required high levels of oxygen. But they were kept there and monitored, right? Astronauts are high profile, and if you have something bad happen to an astronaut on your watch, your career is going to be short. Oh, that's interesting. So that was upright earlier, but we'll do a 0G talk. So everybody invert, and you can read. These are some of the medications that have flown on the space shuttle, and it's very similar to what we still have up there on the space station, right? There's anti-inflammatories, anti-nauseants, anti-diarrheal, pain medicines, Motrin, Tylenol, Norco, things like that. And the vast majority, right, 83% of crew members are using at least one med out of the med kit during their mission. And it's common medications for common complaints. One of the most common things that astronauts get is back pain, because you've unloaded the spine, you've lost the curvature, the lordosis in the lumbar region. You stretch some of the ligaments, and they get back pain. And they actually, so the experienced astronauts, we just had a conversation about this last week. The experienced astronauts undo the bottom of their sleeping bag because you sleep stuck to a wall. Depending on your orientation, it could be stuck to the wall, it could be stuck to the ceiling, it could be stuck to the floor, depending on how you think. But they sleep in right, there's a ring of rooms around the hallway. So there's room. But the experienced astronauts undo the feet on their sleeping bag and then tuck their knees up to their chests and then bungee them. So they sleep all night with a little bit of traction put on the spine, and they say that really helps. Stretching it out tends to help them. But they're taking NSAIDs for that. Motion sickness is a big deal. We talked about this yesterday. Scopolamine is what they tend to use for that, but you don't want a drowsy astronaut, especially if your drowsy astronaut's supposed to fly, whatever it is that you're launching. So then we give them an upper to go along with it. And NASA compounds this method. It's called Scope Dex. It's Scope and dextroamphetamine, and 20% of them use that. I think that number's gone up. The stuff I've worked, the vast majority of people are taking this pre-launch. Acetaminophen, a benzo. Motion sickness is by far the most common, and sort of, it's not true motion sickness. It's called space adaptation sickness, but it has a lot of things in similar with motion sickness. What happens is your inner ear gets really confused without gravity, and so when you turn your head, you don't get the inner ear stimulus. That fluid doesn't behave the same way, so it doesn't feel right. And then when you do turn your head, you may see somebody sideways or somebody upside down. So you just get this real disoriented perception, and they say it's really not enjoyable. So if you watch the astronauts the first couple of days that they're up there, if they're doing media events, they're all turning at the waist. They don't want to move their head at all if they can help it. They say that it gets better. It takes about 3 to 5 days for that to start to get better, and then they're having fun, right? Then you get the videos of them flying down the hallway, doing flips and all sorts of weird stuff. So it doesn't last forever, but then they have to come back. And when they come back, then they get the opposite, right? Any head movement suddenly becomes a really provocative event. And if you have to pull a suit up and over their heads, and they have to do that, even that much will make them puke. So you got to go real slow with them. Any incline that they have to walk on, or any incline that you give them. So if you're loading a stretcher into a helicopter, you want it to be slow and you want it to be perfectly level, because if you dip them at all and they're not expecting it, it's going to get messy pretty quickly. And generally the rule is if you make an astronaut puke, you have to clean it up. Nasal congestion is a big thing. And then there are a number of different ways that we can give the meds, right? Same as here. We can give it orally, IV, IM, transcutaneous. You can do a suppository if you want, intranasal, and then they said intraocular. I don't know what med they were giving intraocular. This one also flipped. So there are a number of things that affect the absorption of those drugs, though. And so the important part of the slide is the one that's upside down here, but it's unpredictable, right? So they did studies with Tylenol where they gave astronauts a dose of Tylenol and then tested how long till they get peak concentration in the blood, and how long does the effect last. And it was different. The vast majority of people achieved a lower peak concentration of Tylenol on orbit than they did on land, but there were a few people that actually had an increase, and they don't have an explanation for it because the numbers are so small, but it's unpredictable. How you respond to a medication here, we hope is going to be the same to how you respond on orbit, but we don't know for sure. And this is why. So on Earth, right, we've got gravity pulling the vast majority or a lot of fluid down to our legs. And if you're one of the people that has to elevate your legs at the end of the day to get the swelling to go down, you can appreciate that. In orbit, microgravity, the opposite happens, right? That fluid is just going to go anywhere. So fluid that's normally in your legs is actually going to start to go north. And that's why the astronauts, when they do interviews, look like they're retaining some water. They're actually not retaining water, but they've redistributed what they've got. and it's gone to their face, and their faces are going to look puffy. They actually come back orthostatic and hypovolemic because the baroreceptors don't like getting that increased volume. And so you actually have a diuresis for a little while in space and then hit a new level, which is great if you're going to stay in microgravity. But when you come back to Earth, and then suddenly that little bit of fluid that you've got that's redistributed has now gone back to where it's supposed to in the legs, you're sacrificing what you've got up north. And so these folks come back orthostatic. 70 to 80% of astronauts that return are orthostatic. And we're pretty aggressive with our fluid load. So they do salt tablets on the way back in to try to get some extra fluid, and then an IV fluid load and an oral fluid load. And there's a whole bunch of stuff going on in terms of trying to figure out what's the best fluid to give. Is it just water? Do they need Gatorade or some other sports drink? They've got one that they're testing, which is glycerin. So you've got a sweet and salty, slimy drink, which sounds absolutely awful, but it's a fair, the volume that they have to ingest in the hours before coming back is significant, and they're still dizzy when they come back. So fluid, right? We talked about blood. If blood ends up on the floor in a code, it's not the biggest problem in the world as long as your shoes are waterproof and you don't slip and fall in it, right? In space, fluid goes anywhere. So we don't use ultrasound gel on the space station because we don't need to, right? A drop of water, surface tension is going to keep it together. So you just use some water and you put the gel on it and you get a good seal that way. And this is, that's Karen Nyberg. That's water just on the end of a straw, right? So if you don't blow all the way through the straw, you can make a big bubble of fluid at the end that then you can drag around with you like a little pet in a leash. This is Don Pett. So Don Pett somehow got bored in space, like somehow managed to have enough time to be bored to an extent. And he is a genius. And his big complaint was, I don't like drinking coffee out of like a juice pack, like a Capri Sun foil pack, because to Don, coffee was the aroma and the taste and just being able to hold a mug. And so he got a bunch of plastic acetate sheets and some tape and thought back to his physics class at one point in capillary reaction and invented a coffee cup. And so that's Don Pettit's 0G coffee cup, which he's now making in his garage at home. I think NASA's told him to stop. But he was making, he had got a kiln and did all this, and he can now drink from a glass in space, or from a cup in space. It doesn't have to be in a pouch. He used, right, surface tension to his advantage. He came up with this. But it's important because, right, that's what a medicine vial will look like in space. So if you pull out epi and you want to draw it up, you don't know, it's not like Earth where it's going to be on the bottom with a meniscus on top. It could be plastered on the side. It could be up on the top of the thing. So you may have to do a lot of gymnastics with that needle to be able to draw it up. And that's something that is going to be a challenge. What you can't see in there, but I'll show you on other slides, is air also mixes into that. So you know those, I didn't have them, but there used to be some sort of drink. It was Orbits or something that had like air bubbles and bubbles of stuff in them. That's what IV fluids look like in space. The bubbles aren't at the top, they're mixed in throughout the fluid. This is what fluid does also in space. So you can see that it's just a big blob of stuff. Is there a problem with where that blob is? Yeah, how do you breathe, right? It's covered, so you can get a blob of fluid that ends up over your mouth and nose that you can't move and you can't breathe through. And it can be a problem, because we've had that problem. So that's Chris Hatfield on the right. He doing a spacewalk. They used to clean the inside of the visors with soap and used it as an anti-fogging as well. And he got some of the soap in his eye, and so it developed, right, started tearing up because he had an irritant in his eye, which was fine because it was just tearing up in one eye, but it got worse and worse and worse. And he said eventually he couldn't see because the puddle formed all the way around his eye. And he's like, all right, that's not right. God gave me two eyes, so we'll still be able to do something with this. Then it got so high that it crossed the bridge of his nose, and then it was in both eyes. And so he's got a TED talk about going blind in space. And so he was outside the space station, and you can't pop your visor and wash it off and put it back down. You're stuck with it. And so he needed help getting back into the space station to get this fixed. Luca Parmitano is an Italian astronaut. There's now a snorkel inside the spacesuit for spacewalks. So he had a similar problem to what Chris Hatfield had, but it looked more like the guy with the water bottle. So his suit developed a leak. and the cooling fluid inside it came north, and eventually started to fill up his helmet right in front of his face. So he almost drowned in space. He was incredibly calm about it. It sounded like other people were a little more worked up. And when Luca got in, he's like, yeah, it happens. But now they have a snorkel inside there so that you can then, the snorkel goes somewhere else inside the suit so you can get access to air if you ever have this problem again. So we do have crew medical officers that fly on space missions. Right now, for a crew of 5 to 7 astronauts, there are going to be 2 crew medical officers. And the reason there's 2 is because everything in space flight is redundant. And what you don't want is the crew medical officer to be the patient and nobody else knowing how to treat them. So there are 2 of them, which sounds impressive until you look at what a crew medical officer is. And they're not guaranteed to be a physician. There have been a couple of periods in the last few years where there was not a physician on board the space station. Right now, there's at least 1 Tom Harshburn's up there. But if it's just a regular crew medical officer who may be an engineer, maybe a meteorologist, maybe a geologist, they get 40 to 70 hours of training in the year and a half before their mission on basic stuff, right? CPR, so you're going to run the code, how to do sutures, how to start IVs, how to draw blood so that we can do some of the research, or if we need to for labs. They get 3 hours of ultrasound training, and then they get a little bit of refresher training every 6 months, 45 minutes to go over all this stuff that you've done just once to a basic level. We're going to make sure that you still know how to do it, and they still do it while they're up there. But that's probably not going to be adequate for future missions. Right now, the International Space Station has got 9 sub packets for medical kit, and a sub packet that looks like a carry-on suitcase. And so there are 9 of those filled with things that you can use, a variety of medications, and you can run a code, you can intubate, you can do musculoskeletal injuries, and what you would expect for medical conditions. There is no Lucas. Do you guys use Lucases here? It used to be a thumper. So an automated CPR device. They don't have one up there. We can talk about that in a second too. And we're capable of restocking on a regular basis, right? The space station's 250 miles above us. We're always sending up resupply. So you can do that. Orion is what NASA is going to use for planetary exploration. So it's a small capsule. We're going to put 7 people in it, and we're going to have them stay in there for 9 months when we go to Mars. So getting outside of low Earth orbit becomes expensive from an energy perspective. And so every pound that you put on there has to be accounted for. And so we're going to go from 9 sub packets to 1 sub packet. And there is a lot of discussion, as you can imagine, about what's going to be in there, right? What's the 80% that we're getting rid of, and what's the 20% that we're going to take? And everybody thinks that their bit should be in that 20%. It's just not feasible. So the contents are to be determined. But everybody agrees it's going to be limited for exploration class missions, and we don't know what the contents of the resupply options are going to be. So this is the crew restraint system, the crew medical restraint system. And we're going to talk about why it's important for some of the other stuff. But you can see things that you can do on the space station, how they differ from what we do in a hospital. Our code meds were limited to 3. You've got epi, lido, and atropine, as opposed to the ones, the mag sulfate and other stuff that you've got in a hospital. We don't fly up simply because we've never had to use it, right? And it's expensive. But you have to tie the crew member down to do anything. And so that's actually Tom Marshburn right there, and that's Chris Hatfield. And this was they're participating in a study that happened here at Henry Ford. We did spinal ultrasound with the astronauts. But what we talked about is how expensive it is to get a kilogram of mass up to the space station. So it used to be, it was about $54,000 per kilo of payload. SpaceX has taken it down. SpaceX's Falcon 9 has taken it down to about $3,000, but that's still an expensive kilogram of stuff, especially if it's something you're not thinking you're necessarily going to use. The plan is for any planetary exploration, you need about 100 liters of IV fluid. So 100 liters is 100 kilos. So do you want to spend $30,000 of your budget towards this and then have to do it every few months as this stuff starts to expire? Or is there a way that we can create fluid up there from the drinking water that we can add salt tablets to? And they tried that. What they initially did was they put salt tablets into a bag of water and hoped that it dissolved. And what happened was, because you have to shake it pretty aggressively because that salt and the fluid dynamics and zero gravity, you'll get a pocket that's going to be high salinity and then a pocket that's basically pure water inside the same bag. So this is IV Gen, and it will create medical grade IV fluids as you need them in space. There's a lot of talk about what we're going to do with 3D printing to print sterile devices 4 things. Like if you need a central line, you'll 3D print it. You need an art line, you'll 3D print it, stuff like that. And then when you're done, maybe you will then reclaim some of those materials to then 3D print the next guy's art line or whatever else it is that you need, or maybe you need a wrench for your spacewalk, stuff like that. So there's going to be a lot of advances in the next little while. So we're going to talk about some code scenarios here. The very first one, so we talked about DCS, Soyuz 11, they came back with decompression sickness. We have had some other events, right? Challenger and Columbia, the autopsies of those astronauts showed evidence of DCS on their remains for every one of those astronauts. We did have, so this was Serena Anand Chancellor's mission, Expedition 56. We had some depressurization on the ISS in August of 2018. And they had to figure out why, right? Why were we losing pressure on the space station? So they do a very methodical check, right? They start close. There's a pressure hatch in between the vast majority of the nodes and the modules. So they just close the one in the middle of the space station and watch the pressure on one side and on the other side. And when they figured out which side had the leak, then they just started sequentially closing doors. So they figured out which segment it was. And then when they couldn't figure out any further, right, with doors to close, then it was a hard target search to find the hole. And they found it. And so that's a 2 millimeter hole that had been drilled intentionally. You can see the bite marks from the drill in part of the Soyuz. And it was part of the Soyuz that was going to burn up on reentry. So it was never coming back and could never be inspected any more than what the astronauts could do in space. But they took pictures of it. They actually went outside and did a spacewalk where they then started ripping some of the insulation off of that part of the Soyuz to get down to the level of the hole and get a look at it. Apparently the Russians have completed an investigation. I don't know what they determined was the cause of it, but everybody agrees it's very clearly intentionally and man-made. It's not a micrometeorite strike or anything like that. It was done with a drill. So the thought is, right, if something like this was so severe that you had a depressurization event inside the space station or inside whatever vehicle we're going to use next, you could use, and Mike Green is a friend of mine. He wrote a paper. He's an engineer and a doctor. He wrote a paper where he did the mathematical modeling that if I put them in the EVA suit, I can use the EVA suit as a hyperbaric chamber, and I can overpressurize the EVA suit to a level that I can treat and crush the bubble. I have now decommissioned that suit. That suit's no longer flight rated. It would have to come back and get refurbished. But it would be something that I could do in a medical emergency and save somebody's life. Arrhythmias are fairly common, and this is an actual rhythm strip of somebody doing a spacewalk. And you can see, I think I counted it out. I think it was a 14 or a 15 beat run of VTAC. Fairly common among astronauts going out the door to do a spacewalk. Right, you've got some remodeling of the right heart. You've got an increased fluid volume coming up there. You've got some stretch. Put them under a little bit of stress, maybe put them in a hypercarbic environment, and you may get things like this that happen. So far, it hasn't caused any problems other than a little bit of a twitch in the person watching the monitor down on Earth. But right, at some point, you may have to defibrillate somebody. And so if we do have to, there is a defibrillator on the space station, and that crew restraint system that I showed you, that cable that you would then strap the astronaut to, does electrically isolate from the rest of the space station. So you can fire it up and ride the lightning and nobody else is going to get shocked. And you can run a code from there. So say things go poorly with the defibrillation and now you have to do CPR in space. Newton's third law suddenly becomes very, very important, right? And so if you push on something, right, the force you exert on that object then exerts the same force back on you. Causes no problems here on Earth, right? I push off with my feet, I then take a step, and then I end up back down on the ground. In zero gravity, if I push off of something with my feet, I'm going up until I push off to something else and stop and come back down. So you do CPR on somebody, right? You better have some way of counteracting those forces and stabilizing. And you can see this is Sunny Williams running on the treadmill. That's exactly what I'm talking about, right? She's got bungees pulling her back down to the treadmill so that she can run in a fashion that looks like running on Earth. They say it's a little uncomfortable, but that's what they do. That's a liter of IV fluid. You can see the bubbles distributed all the way through. So you put that many bubbles into somebody through an IV bolus, you're now treating another medical emergency that you've just created. And so you can do, right, you can put it through a filter to suck out the air, but that limits the rate that you can run this. So you're not running a wide open bolus, right? You're now limited on how effective is your filter. There are some models that are going around where You just basically swing your arm as fast as you can and try to move all that fluid out. Works for a small vial. It's really inefficient for a 1 liter fluid. You're never going to get all those bubbles out. We tend to tolerate bubbles a lot better if it's an IM injection, but none of our code meds are IM, right? Well, they could be, but they're not going to be terribly effective. So you're limited with how fast you can give fluids, how fast you can draw up your medications, and what you have to do when you're filtering them. And then you don't know what's going to happen with this med, right? What's the first pass metabolism? What's the peak serum concentration? So a lot of unknowns. This is what CPR looks like in space. So the two that seem to show the most benefit, the ER technique, which is over on the far right, and then the handstand method. And so the handstand is also limited by astronaut height, right? You have to be tall enough that you can get your feet on the ceiling and then reach above you and do a handstand CPR chest compression on somebody, which is also not terribly efficient, right? That you're going to get pretty tired pretty quickly doing that. And then the other one, the ER technique. So you get your right leg over the person's shoulder, and then you get your left leg underneath along their hip, and you lock your feet in the middle of their back, and then you start doing chest compressions that way. So the first one, the handstand technique, is the one that through modeling and pig cadaver studies during zero gravity flights gets the best depth and rate. So it's probably the one that's going to work. However, the other one's what you're going to do in an emergency while you're trying to get them over to the crew restraint system and strap them down. There is another technique, the reverse bear hug, sort of looks like the Heimlich maneuver. But if you've ever done the Heimlich, you're not doing the Heimlich at 100 beats per minute, right? So you're sacrificing rate for pretty good depth, and good adequate CPR, right? Rate becomes important. So it's got its limitations that way. So say you do get them back after doing CPR and it's time to intubate somebody, the same thing. They have to be strapped down. We're going to do direct laryngoscopy. But if you're going to lift up towards the ceiling in the back of the room, right, you get a good view with the blade, the astronaut better be strapped down, and you should be strapped down too. Otherwise, they're just going to, right, you've now got a fish hook and you're just going to lead them around. And Dr. Dolchowski has tried doing some of this and says that he has some video that he says is pretty hilarious because it's an inefficient technique. And these are people that are experienced with doing intubation. Because the CO2 on the ISS is somewhere between 2 to 5 millimeters of mercury in the atmosphere, CO2 detectors after post-intubation don't work because they're always going to be purple. So you have to come up with something else. So they use what's called an esophageal bulb detector, where it looks like what you would use for neonates for sucking out the nose. So you put that on the end of the ET tube and you compress it and then see how fast it fills back up. And if the ET tube is in the lungs, then the bulb's going to fill back up quickly. If it stays compressed with suction, then you're probably in the esophagus and you goose the intubation. It's time to try again. So you saw that what CPR looks like. Right now, there are 7 astronauts on the ISS. So your code team, right, is going to be a max of 6 because you're going to assume that you're going to be coding somebody. Otherwise, you're not doing it. So imagine trying to run a code with 6 people, and now try running a code with 6 people, 5 of whom may not be medical at all. It's going to be challenging, right? Somebody's going to get tired doing chest compressions, especially doing chest compressions like that. There's probably going to be an emotional component that may not go terribly well, because not only are you not medical and you're now participating in a code, you're participating in a code and somebody that you know very well and probably like. So there's going to be a psychological component. And then what do you do if you're successful? So you get them back. Now what, right? You don't have an ICU to transfer them to. You've got limited meds for all the stuff you're going to need afterwards, sedation, paralytics. And then what caused the code? Can you fix it? Is it something that you have the capabilities of fixing? Proning was something that we had a lot of discussions about recently because of COVID, right? We were proning people here. You can't prone in zero gravity, right? It's entirely dependent on gravity for that to work. Or do you even need to? Because we talked about yesterday, right? VQ mismatching is also a result of gravity. And without gravity, you start to lose some of that VQ mismatching. So maybe you don't need to prone somebody who's in severe ARDS in space. And then if ventilation is a problem and you're ventilating into an environment that's already hypercarbic, right, you're behind the 8 ball. So there are a number of challenges that need to be addressed. And this is a famous picture. This is probably the biggest group selfie in space. I think there are 12 or 13 astronauts here. The vast majority of them, it took a little while to get this picture. And astronauts like to do this because you can get some really cool pictures without gravity, right? You can do everybody in a circle like this. But because of the way air moves in space, you get pockets. ventilation becomes an issue and you have to assist it with a fan. And so you get pockets of CO2. So you put this many people in a pose for an extended period of time and take a picture. There were a number of astronauts after this picture that had headaches and were throwing up because they created a large CO2 pocket that then they were breathing. So it got worse. There are restrictions on how long you can work in an enclosed environment without a fan on the ISS, because you're probably creating a pocket of CO2 and somebody should go check on you. So say something bad happens and you end up with trauma, and there's a lot of risk, right? At 17,000 miles an hour, launch, docking, landing are all dynamic events. Micrometeorites, going out and doing a spacewalk. There are a lot of things that can hurt you and hurt you badly in space. So we can do fast. This is a fast exam that was done on Peggy Whitson in space, just to prove that it can be done. Dr. Dolchowski was on this paper as well. So it can be done, but how do you interpret it, right? The fast is entirely dependent on gravity is going to create pockets of fluid in predictable places. But is that going to happen on the ISS? Are you going to get fluid going to a dependent space? What is a dependent space in zero gravity? And then what are you going to do, right? You've got to come up with some way to now resuscitate and stop the bleed. Are you going to be able to do that on orbit? And so you may have to do hemorrhage control and a transfusion. And there are some discussions about how that's going to occur on these missions, especially when we go to planetary exploration. Are we going to start selecting crews based on blood types to match so that we have walking blood banks up there? And then what do you do? Because right, we already talked about them being hypovolemic at baseline. So now you're going to take somebody that's hypovolemic and make them donate to somebody else. And bone remodeling and bone marrow function changes in space as well. And so red blood cell mass tends to be decreased compared to terrestrially. Relative is the same, right? They have the same relative red blood cell mass for the volume of fluid that they have, but it's less than ideal. So you're going to draw blood from this person who's now not going to regenerate at the same rate that they do on Earth to try to resuscitate somebody else. At what point does this become futile? Are you hurting somebody else to save something that potentially you should have triaged black and moved on from? And these are some of the discussions about what you're going to do for blood types in terms of making your walking blood bank. And the reason you're going to have 2 O donors is in case you have to donate blood to one of the O donors. Same reason you have 2 crew medical officers. So in conclusion, medical emergencies in space are obviously going to be extremely challenging events. And what we know on Earth doesn't necessarily apply to how we're going to run things in a microgravity environment. And it's not an if, right? It's a when. At some point, something bad is going to happen up there and we're going to have to respond. The people that are responding are going to have a pretty good knowledge of human physiology as well as the unique environment and what that means. So something that seems incredibly simple here, and we can, right? I don't know how many of you check your ACLS algorithms as you're running a code, and my guess is probably very few of us, right? We have it down to muscle memory at this point. Unfortunately, we've run enough code, so that's where we're at. But that muscle memory doesn't necessarily apply to what you're doing here. Exploration class missions, if we're going to have a communication delay, they're going to have a physician on board, and everybody's starting to accept that. And even some of the shorter duration missions that are happening in low Earth orbit, they're talking about starting to fly more and more doctors so that we get that expertise and that experience, and research is becoming very, very important. And the good news is it's going to lead to new advances in technology and knowledge. We're going to have to do more with less the further and further out we go. So it'll be extremely exciting to see what happens. And it's going to happen over the next 10 years. You're going to be amazed at how fast, now that the commercial side has started up, the acceleration and the growth is going to be incredible, astronomical, if you'll pardon the bad pun. So with that, these are the 3 kiddos. My wife took this picture, one of my favorites, but I'll open it up to questions. Thank you. Sir.
I have a question. Thanks for a nice talk here. It was very interesting. Do they do focus exams in space? Do they do it as needed, or they are frequently checking on the astronauts?
So
what exams imply, because
yeah,
they diagnose
the IJ. Yeah. So they were doing a study called fluid shifts, trying to figure out. So there's a condition called space adaptation neuroocular syndrome, called SANS. Used to be called BIP, and I can't remember what BIP stands for anymore. But what happened was they had some astronauts that went to space, spent 6 months in the space station and came back and suddenly needed glasses. And these were people that for 40 plus years, perfect eyesight, were military pilots, no problems. But we're having some visual changes that needed glasses. So they got an eye exam. And the eye doctors noticed that they had optic disc edema and flattening of the globe. The posterior aspect of the eye was flat. And so they started noticing more and more astronauts that had done long duration space flight. So the thought was, it's just right. You've got optic disc edema. It's got to be cerebral edema, and intracranial pressure is elevated. And they had a couple of astronauts that post flight their LP opening pressures were elevated, but asymptomatic otherwise, right? Didn't have headaches. They weren't throwing up. They weren't ataxic. They just needed glasses. So the thought was, it's a fluid shift, right, from the legs to the head. You get the puffy face, you get this optic disc edema. So let's start looking at what happens with the, right, how do we get increased cerebral drainage, venous drainage? The lymphatic system became very important. And so they were doing these studies where they were looking at flows in the IJ. And the astronaut in question wasn't participating in the study, but somebody, they suddenly became acutely aware of everybody's neck because they were scanning some of them. And somebody looked at her one day and said, "What's going on with your neck?" And they could see it. They could visibly see a cord. And so they did an ultrasound, because they'd all been trained at this point on how to do IJ ultrasounds, and there was no flow. And then there was retrograde flow on the contralateral side. So the vast majority of the POCUS exams that they're doing are for a research study. And there are a lot up there. So there's the ultrasound system you saw, I can't remember, Samsung, I can't remember whose system it is that's up there. So I'm gonna say I can't remember. But they just recently flew 2 butterflies. So there's 2 butterflies up there as well. So they're starting to use it more and more and more to get that knowledge base.
Do they know how to interpret it, or they have to send images to Earth, or then they have to?
So right now they're coming back down to Earth, and somebody's looking at them. So all the research studies that we've done, it's been telehealth of some sort. And Henry Ford created the ultrasound system or the protocols and the training method. Henry Ford University, I heard Chris Clark talk about it today, one of the ER ultrasound guys. But it was Dr. Dolchowski that started that up as well, with Kat Garcia, who was a sonographer at NASA. And it's basically ultrasound for dummies, right? Here's your probe, here's your indicator, here's the part of the body we want you to look at. And then they would talk them through it. Right now, fan this much, fan that much, rotate. That's a good image, save that clip, press this button. But we're gonna have to get away from that, right? If we're gonna do a 20-minute comms delay in one direction, you can't do that, right? I'm not gonna hold the probe in the same spot for 40 minutes for you to go, no, bad picture, move. Sir? There is. So that would be a discussion, right? Because bringing somebody back intubated and ventilated is challenging. There would probably be, can we fix it up there? Can we stabilize it? Because when the IJ thrombus was noticed, the initial knee-jerk reaction was, they need to come back, and they need to come back now. And then cooler heads prevailed, and they're like, wait a minute, we got the medication up there to treat this. There's no neurologic issues. We're monitoring it. And do you really want to have a fresh thrombus hit the ground at 4 Gs? Or would you like it to mature a little bit, and we can treat it, and then maybe when it hits the ground, we're not risk of flinging it off somewhere we don't want. So I think it's like any other medical experience. It's really going to depend on the doctor on that particular day and their clinical acumen and decision making. But every vehicle that flies right now, we have tested that I can put an astronaut in a body bag, strap them into the capsule, and bring them back. So we've had those awkward and uncomfortable conversations. They're not public, but we've done the testing, and we know that recovery vessel, the medical bay on there, has 4 body bags in it. We don't talk about it. They're hidden away. I had a medical student, we were getting ready for one of the reentries, and they happened to look underneath the cabinets and pulled this packet out. I'm like, what is this? Why is it buried underneath the medical chest? I was like, what do you think it is? And they said, well, it says body bags. That's right. Like, I don't know, where's the confusion? And she said, well, why do we need 4? How many astronauts am I bringing back? Right? This is how, right, if anybody's going to get a paparazzi picture, they're going to be in a body bag. I'm not having a body just on a stretcher. And so then she wanted to put them somewhere. She's like, well, they're buried on the floor in the back underneath the cabinet. Like, we should put them in this drawer. I was like, you do not, right? The astronauts do not need to see the body bag. And we've got flags. We've got 4 American flags, or whoever it is that's flying, so that, right, we can drape the. So we're aware that this is a very dangerous business, and at some point something bad is going to happen. And the best thing to do for something bad is to be as prepared as possible. Because at that point, right, dignity and respect is about the best thing you can do.
Is there any work being done towards generating like artificial gravity, for example, like centrifugal force or something of that nature? Because that would seem like it would solve a lot of the problems. Yeah, and so I'm not going to pretend to fully understand that, but there are people that are working on it. The challenge is the arm has to be, I can't, but it's huge, like hundreds of meters in length. Otherwise, you get a real big difference in terms of angular acceleration. Right, say it's a 6-foot arm or a 6-meter arm or a short one, right? If you're at the 6-meter mark, you're getting 1 G, and if you're halfway back, then you're getting significantly less. That now it's not even worth the energy and the effort to try to. You're not getting any benefit, and you have to spin that arm to get that 1 G at that 6-meter mark at a certain velocity. And there's a big gradient the shorter your arm is, so it's got to be a massive arm to then make it so it's pretty uniform no matter where you are inside that environment. They are talking about it, but there are challenges that go along with it. And then how do you spin it, right? That's expensive from an energy standpoint.
A little bit about the training you need to do what you do in aerospace medicine. You have to be critical care for it. What paths do you use to get there?
Yeah. So the officials, so aerospace doctors are not aerospace doctors, are not aerospace doctors. A very wide range in the small population that we have. So to be aerospace boarded, you just have to have a primary residency in something and an MPH. That's the requirement to get an aerospace board certification. So there are some of the early NASA flight surgeons were OBGYNs, which is interesting because we weren't flying women. So right, your area of expertise. But yeah. There are neurologists, there are family medicine providers, there are ER docs. NASA doesn't have a single critical care boarded person working in their office. Psychiatry is becoming a big thing. The very first Mayo aerospace fellow was an interventional radiologist, which is fascinating, but we don't do interventional radiology anywhere in the zero-G environment. But he's now a brigadier general in the Air Force, so he's doing well for himself that way. So it's varied, and it depends on what you want to do with it. So the reason I got the gig that I've got doing the consulting work is for contingency planning. So if something goes bad on launch or landing, I suddenly end up the guy that has to clean up the mess. And it's in the contracts for some of these companies, right? NASA's got flight docs who know the astronauts, right? Their panel of astronauts. So it's like you're now taking your family med doc or your clinic doc who knows you well, has known you for years. You've got a relationship on board this vessel. But if you're in a car accident in the lodge, you're not going to clinic, right? You want a different doctor looking after you. And so I'm that different doctor that I will clean up the trauma and deal with the medical emergency. Your doctor's there if everything's okay. So you've got a familiar face and somebody you can talk to, as opposed to, right? Because that's the biggest challenge in the ICU and the ER. I don't know you, you don't know me. I'm potentially telling you something absolutely devastating. And now we've got trust issues, right? Because you don't think that, well, you don't know me. You hear that all the time, or you don't know grandma, or you. So that's what they're there for. So then when I turn and look to the NASA doc and say, listen, this is what we're dealing with. This is what I'm worried about. We've got a collegial relationship that then they can turn around to their astronaut and go, he knows what he's talking about. Or that's right, that's the plan, that's what we should do. And now the astronaut will buy into it. Luckily, we haven't had to deal with that, but But that's how I ended up where I am. But psychiatry is going to be a big thing because we're going to have to pick these people very, very carefully. And there's a need for it. And there's not a lot of demand out there. There are very few aerospace psychiatrists. So you can do pretty much anything and then end up in aerospace. But it's just, right, I'm not going to be doing aerospace psychiatry. That's not my bad. So what your background is dictates how you fit into the system working with these folks. Cool. Well, thank you very much. I've enjoyed this. Oh. Dr. Bradley, how are you, sir?
Good to see you. Good to see you.
You doing well?
Doing well. You?
Good.
I mean, obviously.
Yeah, I'm doing fine. Yeah. I have no complaints.
Thank you very much.
No problem. Thank you.
Thank you so much.